All right, everybody, I think we're going to get started. Good morning. So my name is Elena Mazurkowitz, and my presentation is on eating disparities in gender and sexual minorities. So getting started, what does it mean to be a gender or sexual minority? So anybody who identifies as either lesbian, gay, bisexual, asexual, transgender, queer, intersex, which is a person who is born with reproductive sexual anatomy that does not always fit the boxes of male or female, and oftentimes they get surgery to make their bodies fit their binary ideas. Or also two spirits, which is having both a feminine and a masculine spirit, questioning, and then more. So pretty much anybody who does not identify as heterosexual or straight can be in the sexual and gender minority. And these populations are known to have more eating disorders, mental health problems, body dissatisfaction than a lot of their heterosexual peers. So this can be due to a number of different reasons. The top three are stigma, discrimination, and minority stressors, because they all significantly impact behavioral and physical health. And a lot of families and parents pressure their children into these traditional gender norms when they're very little, just by like the clothes that they buy them or the toys that they allow their kids to play with. So a lot of times they're pushed into the gender that they were born with, even if they don't believe that they are that gender. And then bullying is extremely common among school-age children, and something that maybe if you are not in the community that you think about, but gender-specific bathrooms can cause a lot of traumatic stress for some sexual and gender youth. And I just would like to say as a disclaimer, as I go through the rest of my presentation, I will be referring to the LGBTQ community members as what they identify as, and then comparing them to heterosexual individuals. I will not be referring to any of them as homosexuals, because I did do some research and I found out that homosexual is actually seen as a very offensive term to people in the community, and it is commonly used by anti-gay extremists to put down gays. So I did not know that before doing this, so I will not be using the term homosexual at all. So yes, and then overlooking some of these stressors can increase the risk of development and behavioral issues, substance use, eating disorders, etc. So specifically, I'm going to be looking at diet-related disparities. And what are they? They're defined as differences in dietary intake, dietary behaviors, and dietary patterns in different segments of population, resulting in poor quality diet and negative health outcomes. So this can affect people's disease incidence, morbidity, mortality, and definitely their quality of life. So for some people, it can mean an eating disorder. Others, it can be food insecurity. And then for other people, it can just be the low intake of nutritious foods and a high fat intake. So why are LGBTQ individuals at a higher risk for developing eating disorders? So there are a number of different broad categories that contribute to eating disparities, kind of like the example of the picture on the right. So you have economic, cultural, individual, nutrition, like all of that plays a part. But the four main contributors in the community is bullying, trauma, cultural pressure, and loneliness. So eating disorders commonly develop from 12 years old to 24, which is also around the same time bullying is very prevalent. And according to NIDA, they reported that 65% of people with eating disorders say bullying contributed to their condition. So bullying definitely has a big effect on that. Next, trauma. So traumatic experiences like sexual abuse, domestic violence, even a death can all lead to eating disorders. And excuse me. So this could be for a number of reasons why people feel like they go into eating disorders, and it can help them feel numb. It can change their physical appearance to feel less targeted. Maybe some feel like they got targeted because of the way they look, or because they also feel like they have a sense of control, like that traumatic experience. They had no control over it, but this they do. Next, cultural pressure. So I don't think being out of the community, we realize how much pressure that even the community puts on people who do not identify with certain genders. And so some may develop disordered eating habits as an attempt to get secondary sex characteristics. And cultural pressure to look a certain way is very, very, very problematic in gay men who try to be dangerously small sizes. And lastly, we have loneliness, and no matter what sexual or gender identity that you have, anytime somebody feels isolated or alone, it can contribute to the development of an eating disorder. And a lot of people in the LGBTQ community feel this way because they can be scared to come out in case they will not be accepted, or they feel like they'll lose friends or family because of this. So it can put them into a deep state of loneliness and isolation. So why did I pick this? I am not part of the community, but when I moved to Green Bay and I got my job, I met Jacob, who is on the left. And Jacob is a coworker and a good friend of mine, and I interviewed him to kind of talk because I remember one day he told me at work, it was like 7 p.m., and he said that he was trying to lose weight and all he had that day was a cup of coffee and a diet pill. And I was like, well, that is not good at all. So Jacob is 100% Polish, and he grew up in a very Catholic high school household. He also went to a private Catholic school. And when he came back from Poland, at one point in his life, he had gained some weight, and that was also a time he transferred from his private Catholic high school or middle school to a public middle school. And around this age, 14, 13, is when he started to experience bullying. And when he wouldn't actually know what these terms meant, or people wouldn't say it to him, but they would be said to his best friends, who would then come and be like, people are saying you're gay. Are you gay? And he really wasn't sure. He was just acting like himself. And then he would soon get punished for acting like himself. So he turned to the internet to look at these terms and what they meant. And on the internet, that's when he found some of his idols, and that's when he got on dating apps, and he started looking at the community through the eyes of social media. And he actually found the most struggles within the community because the stereotypical gay on there is, really shredded and blonde hair and tan and thin and rich, and he looks like the fun friend. And even some of his other idols, like, he looked up to them, and it was so damaging because he was trying to look like them, and those looks were just not attainable. And so at age 17, he was diagnosed with anorexia nervosa, and he was admitted to a hospital at around 18 for it. And so he's doing better now, but at 19, he had a binge eating disorder that came along with a drug addiction. And I remember he told me that the same high he got off drugs was the same high he got when he didn't eat. And he enjoyed feeling like nauseous, lightheaded. And he also found that not eating was a better excuse than eating and then having to get rid of it, because he could just say he ate before, or he wasn't feeling well, or he had a way to get out of it versus eating and then having to go throw it up. Now Jacob is doing a lot better. He is 21 years old, so this was a couple years ago. He has a therapist. He has found drugs that help him, and he told me that the biggest thing with helping people in the community is gaining their trust, which was a very important thing for, I feel like, a person who may deal with somebody in the community in the future. You have to gain their trust first for them to really want to get better and fully believe you and take your word. So now getting into my studies, when I did my studies over the 3, I wanted to look at the different stages in people's lives. So the first one was in adolescence, my second study is in college students, and my last one is in adults to see if eating disparities changed along the life cycle. So my first study is sexual orientation disparities in eating disorder symptoms among adolescent boys and girls in the United Kingdom. And this was kind of the first type of sexual orientation disparities in eating disorders done in the UK. And eating disorder symptoms were assessed at 14 and 16, and then only sexual orientation was looked at 16 years old. And these participants were actually recruited back when their mothers were pregnant, which I thought was very interesting. So at age 14, a little over 10,000 children were still enrolled and got sent questionnaires. And then at age 16, a little over 9,000 children were still enrolled. And this sample was said to have represented the UK population. So what they looked at through these questionnaires was they asked about sexual orientation, which they split into heterosexual, mostly heterosexual, but attracted to the own sex, bisexual, and 100% gay, or not attracted to either. And then they also looked at eating disordered behaviors. So they assessed purging, overeating, binge eating, dieting, things like that. And then they also did a body image dissatisfaction scale where they asked participants to rate certain parts of their body. And they were asked to go from extremely satisfied to extremely dissatisfied. And then co-founders, they looked at weight status, race, ethnicity, and lower socioeconomic position. And then weight and height was collected only at 14 years old, which they were used to find their BMIs. So what were the results? So due to the small sample of bisexual, gay, and lesbian identity categories, they were all kind of grouped into one. So there's a gay and bisexual and a lesbian and bisexual instead of having them separate. And what they found was notable sexual orientation disparities in body dissatisfaction and disordered eating symptoms were found in both male and female at both ages of 14 and 16. But specifically, gay and bisexual males had over 2.5 times the odds of eating disordered behavior than completely heterosexual males, and lesbian and bisexual and mostly heterosexual females had higher odds of disordered eating behaviors than their heterosexual female peers. For body concerns, gay, bi, and mostly hetero girls were mostly dissatisfied with their body than heterosexual girls. So what we found was that it revealed that eating disordered symptoms already were pretty stark by mid-adolescence, and that victimization and internalized homophobia may worsen disordered eating by negatively impacting self-esteem, increasing body shame. So there were a couple of limitations to this study. First, it was the setup. So sexual orientation was only assessed at 16 years old, but not at 14. So it kind of limited the analysis to compare disordered eating behaviors at 14 and 16. So I kind of wish they looked at both in both ages. And then secondly, because they didn't really have a huge sample size, they had to kind of group the sexual minority subgroups together instead of allowing a gay and a bisexual group. And then lastly, there were really broad ranges of body image concerned and disordered eating behaviors. And the range of symptoms assessed may not really be inclusive of the extensiveness of concerns and behaviors that youth of diverse genders and sexual orientations may exhibit. So now we have my second study, and this is eating disparities in sexual and gender minority college students. So how they did it was they did a threefold study. And this was an interesting study because not much research has been done to compare the eating disorder rates among transgender and cisgender populations. And I kind of find that alarming because according to a study, actually, eating disordered behaviors are very common among transgender college students, with about 28 to 45% experiencing them. So this study is examining rates of self-reported lifetime anorexia nervosa, bulimia nervosa, and past year EAI, which is the pathology-specific academic impairment by gender identity and sexual orientation. And they also looked at the associations between gender identity, sexual orientation, and eating outcomes, and then overall, who has the greatest risk of an eating disorder. So the participants were Minnesota college students who all participated in a college student health survey from 2015 to 2018. And they did a range of 27 college and universities. And students were selected by being sent a postcard notifying them of their eligibility. And then once they accepted it, they were sent a personalized link through an email. And overall, it got around a 40% response rate. So what these looked at, again, was gender identity, which include a broader range than the other one, which asked them if they identified as male, female, trans female, genderqueer, if they preferred an alternative identifier, and then cisgender men, cisgender women, and TGQ, which was trans man, trans female, trans woman. And then they also asked about their sexual orientation, which just asked if they are heterosexual, straight, gay or lesbian, bisexual, or if they were not sure. Next, they figured out eating disorder diagnosis by asking if they had ever been diagnosed with any of the following. And if they had answered yes, they asked if it was within the past 12 months, more than 12 months ago, or never. And then Coviart was just like the age and race of the participants. And lastly, the EAI was looking at how eating disorders have affected academic performance. And they asked if they do not have this issue, if they have this issue, but their academics have not been affected, or if they have it and it has. Okay, so what did they find? They divided up the results in 4 different categories. So they did comparison by self-reported eating disorders and impairment by gender identity. And what they found was the results revealed gender differences in self-reported lifetime anorexia nervosa, bulimia nervosa, and past year EAI. Specifically, cisgender women and TGQ students reported higher rates in eating outcomes more than cisgender men. And then next, the study compared self-reported eating disorders by impairment of sexual orientation and found that specifically gay or lesbian, bisexual, and other identified students reported higher rates of self-reported lifetime anorexia nervosa, bulimia than heterosexual students. But only bisexual and unsure students had higher rates of EAI compared to heterosexual students. And then within the gender comparison by sexual orientation, they found that higher rates of the EAI outcomes in LGBTQ students was found more prevalent than in heterosexual students. And lastly, marginalized gender and sexual orientation comparisons compared the rates of all three categories among LGBTQ and TGQ students. And the results showed the highest self-reported was in all three was bisexual cisgender women, which I thought was interesting. So this is kind of like the total results and how they divided it all up. And so you can see that lesbian and bisexual cisgender women experience the highest lifetime anorexia nervosa and lifetime bulimia nervosa. And then for the past year EAI, which means that their eating disorder was affecting their academics, it was mostly found in bisexual and unsure cisgender women. So in conclusion to this study, it revealed that heightened rates and increased risk of self-reported eating disorder in cisgender women or TGQ college students relative to their heterosexual or cisgender peers. And I found it interesting, but college students who are unsure of their sexual orientation and bisexual cisgender females reported that experience heightened stress due to the uncertainty with identity exploration, and they had the heightened frequency across all three eating disorder outcomes of interest. So in future studies, they should aim to examine the mechanisms associated with heightened rates of eating among TGQ college students, bisexual, cisgender women, and cisgender men and women who are unsure of their sexual orientation. So the limitations of this was it included a self-report assessment of eating disorders, but it did not capture all eating disorders. And then it also combined past year and lifetime diagnosis due to a smaller sample restriction. And then they asked for the race and ethnicity of these participants, but they didn't actually use them in the results, which I thought was interesting as well. And then so because they looked at transgender males or females, it did not include the assessment of the sex assigned at birth for some of these participants. So maybe that would have changed or been interesting to see if it was different. And then it was a lack of diversity because the study just focused on college students in Minnesota. All right, and my third study is Disparities in DSM-5 Defined Eating Disorders by Sexual Orientation Among U.S. Adults. So the objective of this was to examine lifetime prevalence estimates of eating disorders like anorexia, bulimia, binge eating disorder as a function of sexual orientation. And participants of this were U.S. adults who took the National Epidemiological Survey on Alcohol and Related Conditions. And other studies have actually found that sexual minority adults have had higher rates of alcohol and substance use disorders, and that experiences with discrimination worsen these risks. The overall response rate for this study was 60%, and then data was adjusted for non-response and weighted to represent the entire U.S. population. So I'm gonna go back real quick. So also the measurements that they used was they had a creation of eating disorder diagnosis, and it was consistent with those previously used in that NESARC3 database, which is that national survey on alcohol and related conditions. And then they also asked for their sexual orientation. And the thing about this study was they looked at perceived discrimination due to sexual orientation. So they asked if they experienced discrimination during the last 12 months, prior to the last 12 months, and then they asked 6 discrimination questions, and they asked if they felt this way because they were assumed to be gay or lesbian or bisexual. And these questions include if they had any troubles with obtaining health care or health insurance, with how they got treated when they got care, public settings such on streets, restaurants, if they were treated any differently, and then if they were being called names or being made fun of or anything like that. They also looked at the socio-demographic characteristics, which was age, sex, ethnicity, and race. And now over here. So the results, again, just like the other one, were split into a couple different categories. So participants by sexual orientation, they found that greater proportions of sexual minorities were actually female, non-Hispanic, Black, and had a lower income. And that being called names and discrimination in public were the most commonly reported forms of discrimination among sexual minorities. And then for lifetime eating disorders by sexual orientation, they found that these eating disorders diagnoses were significantly higher among sexual minority respondents than heterosexual respondents. And eating disorder by sexual orientation by race and ethnicity, they actually found that there was no significant main effects of sexual orientation or sexual orientation by race and ethnicity interaction, which was interesting. And then lifetime eating disorders perceived discrimination among sexual minorities. So sexual minorities reported that they had perceived discrimination, had significantly higher prevalence of anorexia nervosa than sexual minorities who reported no discrimination at all. And lastly, they looked at participants' characteristics and psychosocial functioning by perceived discrimination among sexual minorities with any specific eating disorder diagnosis. And they found that younger and less likely to be female reported lower levels of education than sexual minorities who denied discrimination. So in conclusion, the present study documents that sexual minority adults may be a group at particularly elevated risk for developing these eating disorders at some point in their life as well. So just because you're an adult does not mean that it does not happen to them. And some of the limitations to this study was underreporting. So this study was actually how they got the answers and how they received the information was through interviews. And so underreporting may have occurred because it was a face-to-face interview and people may have been too scared because of stigma or discrimination to come out and actually explain and give the correct answer. So maybe next time they should do it over the phone or a little bit more anonymously, and they may get more information. Another limitation is that the assessment of the eating disorders in the present study relied on the diagnostic tool that hasn't really been examined for reliability for specifically eating disorders. So we don't know if that was actually a good tool to use. And then lastly, they had a very small number of participants and didn't really have a lot of different sexual minority subgroups, which could have been, could have changed the results. So overall, how can dietitians help the LGBTQ community? And first off, as a dietitian, we will be working with other team members. So working with a team who is comfortable and competent of, dealing with LGBTQ community members will make sure that they are getting the most compassion and thoughtful care. And then also creating a sense of group work and community. Groups can help people in the community feel less isolated and alone and kind of bring them to other people who are dealing with the same thing as them. When we do give them intake information, we should be mindful to not assume gender or sexual identity as well, which can be difficult because a lot of times we have different recommendations for males and females. So we have to make sure we're being aware of that. And then according to a healthy weight in lesbian and bisexual women study, they found that programs that focused on the overall health, that focused on the overall health and well-being of these participants were more successful than just specifically working on losing weight and things like that. And that when they did this, their participants were more able to meet their goals. And then finally, you can bring awareness and advocate for these individuals and lobby for LGBTQ rights in the healthcare system, because we play a central role in also treating eating disorders and taking care of these people. So, all right, that is all I have. Does anybody have any questions?
Thank you, Elena, for that great presentation. If anyone has any questions, they can either put them in the chat or raise their hand. I just wanted to remind you to please fill out the evaluation link for Elena's presentation and give her a little feedback on how she did today. And then also the next presentations start at 9:50, and they are either Jessica's presentation titled Chronic Kidney Disease and Protein, or Flora's presentation titled Dysphagia in Head and Neck Cancer Patients.